Got it.
Good morning, Rob Newton. I am delighted to have you with me, and I'm delighted to make sure that I've pressed the record button this time so that we can capture all of the wonderful conversation and hopefully repeat some of those great responses and questions that we had in our first take. I'm here
Fantastic.
today.
Thanks, Katie.
I'm here today with Professor Rob Newton. Professor Newton is one of the most accomplished researchers in exercise medicine. He is the Professor of Exercise Medicine at Edith Cowan University. He is extremely experienced, both clinically, hands-on, set-up execution, set up the Vario Clinic, which is a great gold standard for clinical execution as part of his research work into both prostate and now moving more into that palliative space, which I just find fascinating and support as well. The quality of the research, Rob, in those spaces. We haven't got time to delve into them today, but I'll list a few of my favourite. I'll list my favourite 5 in order of sequence with this particular recording. Today, I have Rob here with me to talk about GLP-1 and GLP-2 drugs. That is a really interesting space at the moment in the marketplace from a pharmaceutical point of view and an exercise medicine point of view. And I thought I'd just kick things off, Rob, with asking you about why you in particular are energised and keen to share research and potential risks of the drug class in Australia over the next 3 to 5 years.
Certainly. Oh, thanks, Katie, for the opportunity. And I think at the core of it is that you and I've been working as accredited exercise physiologists, working clinically for decades now. And it has proven exceptionally difficult to help people to maintain a healthy body weight. The population is increasing in terms of their levels of overweight and obesity, and the proportion. Australia is roughly 2 in 3 people in Australia are now overweight or obese, which of course has caused enormous problems. But I mean, personally, obviously it's very difficult for the individual. The comorbidities that are associated with having excessive body fat, such as much higher risk of cardiovascular disease, metabolic syndrome, and the associated type 2 diabetes, etc. And also, of course, there's a major cost to the Australian health system, which is a real concern. That's why I think I'm particularly excited about the new, relatively new, I guess, range of these weight loss drugs, which are proving very, very effective. I mean, we have exceptionally large and high quality studies now published in New England Journal of Medicine and etc., some of the top journals in the world, and showing, just quite astounding weight loss with that, which is very, very encouraging. And we, for these patients or individuals who we have great difficulty in helping them to lose weight, this is really a changing point in time in terms of their management. I think it's timely because, of course, the reasons for the burgeoning overweight and obesity epidemic, if you like, is that we're pushing back against the food industry, and this enormous with incredible resources, and their market goal is to try and make food more readily available, more accessible, in many cases cheaper. And they also actually design the food so it is somewhat addictive in terms of high levels of salt, sugar, and fat. And that's what we're pushing back against. Just an absolute behemoth of an industry. And
it's I mean, even the diet, it's a whole nother, we'll have to set up another interview around that space with the team that we work with, wonderful team. But it is not, I've often said it's about the psychology of obesity that is really key, because that's also one of the reasons that I'm, like you, I'm very excited by the potential opportunity for healthcare reform with these drugs.
These drugs, absolutely. And it is, look, it is, I mean, obesity is now recognized more of a disease. It's not a choice. I think that it's also been exacerbated by, modern society and the issues that people have around mental health, anxiety, etc. And they are turning to food to soothe and to help their pleasure centers, and that's what's driving it. So it is a disease in many ways. With these new class of drugs that are highly effective, initially used to treat type 2 diabetes very effectively, but now the actual weight loss effects of them is well established now. However, as you and I know, there are problems. There are side effects. All drugs have a side effect. Aspirin has side effects. And with these particular class of drugs, the major side effect, apart from the fact that many patients will have nausea, diarrhea, in some cases vomiting, there have been reports also well documented of some mental health changes as well. It's rare, but there are people who are suffering from that. We have these GLP receptors throughout our body, including in the brain. So of course, when you alter the levels of these hormones, essentially, you're going to produce changes in every single tissue in the body. It's unavoidable.
Yeah,
And
there's a couple of really interesting papers on that, aren't there?
Yes, absolutely. And these are things which have to be managed and supported. And I think for me, one of the most concerning side effects is the loss of skeletal muscle that occurs with these drugs. So the drugs work, of course, by substantially suppressing hunger. So people just eat less. And so that creates an energy deficit. And so, which is the reason why they lose weight so quickly. And over the initial 12 weeks or so, they can lose as much as 15%. Around some studies reporting that 15 to 20% even of their body weight in as little as 12 weeks. However, those studies which have examined actual body composition and seeing, well, what actual tissues are being affected here, around 30 to 40% of that actual weight loss is skeletal muscle mass. And that's a major problem. And because, of course, our muscles are absolutely critical. They're critical for movement, to keep us functional. They're critical to maintain muscle mass, particularly as we age, to avoid early onset of frailty and disability. But also, we now know that our muscle system is also an endocrine organ. Our muscles produce a range of hormones and what are called cytokines. These are signaling molecules that control all the processes in our body. And they're absolutely critical for managing such things as glucose tolerance and the management of even of cancer and how we suppress our cancer, the development of cancer in our bodies. So it's a real worry, the fact that these patients lose such a considerable part, not only of fat, but also of muscle tissue.
I think
now
your conversation, that comment about body composition is key, Rob, isn't it?
Yes, yeah, absolutely.
The language that that should be used in this space and should be encouraged to be used is around body composition, not around body weight, because I think all of those, it's a really simple point for listeners that, having that conversation around, you may be losing body weight. And I've got 2 current patients in exactly that predicament where they've lost enormous amounts of weight, but it absolutely has been probably, I think, a little bit higher than that, maybe 40 to 45% lean muscle mass loss in the male in particular.
Yes.
It's a huge deficit. Could you just speak a little bit for listeners just clinically to the impact of that degree of muscle loss on whole health systems, heart health, blood sugar levels, etc.?
Oh, absolutely. So the main sink, if you like, for glucose in the body, apart from the brain uses an enormous amount of glucose. But the other main sink, of course, is our muscles. And even at rest, our muscles are absorbing, capturing, and storing glucose as glycogen. And that pulls it out of the blood, of course, and helps to control your blood sugar. Now, it's like a reservoir. The larger the tank, if you like, the more glucose that it can hold. And so when you have this loss of muscle mass, then it can impact your metabolic health. And then that, of course, then translates to increased risk of cardiovascular disease, so heart attack and stroke as well, because the muscle system is very, very important for maintaining homeostasis or equilibrium within the body. We think of the muscular system and the adipose system as yin and yang. they're both absolutely critical. You can't survive without fat tissue. It's also an endocrine organ. Your adipose tissue, the fat in your body and around your organs, is also constantly releasing hormones and cytokines. It's constantly signaling as well. In a normal body weight person, it's in balance. Yin and yang is in balance, and the systems perform correctly, and you don't have the advancement of chronic disease. But when you have an imbalance where muscle is low and fat is high, you're in a very bad situation there where the signaling from the adipose tissue, the fat tissue, is overwhelming. And that's what's driving chronic disease development, including cancer as well.
You say heart disease, Rob, as well, but then you've got the hardware structures at risk, you know, the osteoporosis and the osteopenia, particularly for those people that have one pre-existing chronic disease already. Just the impact on bone health, the sudden loss in muscle mass.
Well, we've got unfortunately, what we're seeing is that osteopenia, so the early stages of osteoporosis, and osteoporosis itself is occurring at earlier and earlier ages. And so people's becoming brittle in their bones and more likely to fracture at earlier and earlier age. It was once thought of as only a disease of old women, and you know, a considerably advanced age before their bone density got to that point. But we're seeing it early and early. And the reason why is that people are just less physically active. In particular, people are not doing very vigorous activity, in particular resistance training, or doing in their workplace or in their recreation. They're not lifting heavy things, and so their bone density, their bone bank, if you like, is not as great as it as what it has been in the past in previous generations.
So
of course, when we diet as well, any program which aims to reduce body fat through caloric restriction, either whether it be through surgery or just reducing how much you eat, or these weight loss drugs as well, it's not only a fat loss program, it's also a muscle loss program. And if it's conducted over a sufficient period of time, it's a bone loss program as well. So what's happening here is the body is saying, wow, I've got an energy deficit here. I have to maintain the levels of glucose in the system, in the circulation. That's essential, obviously. The brain can only use glucose for energy. And so the system works hard to try and maintain and stabilize. It has to get the energy from somewhere. So if there's insufficient energy intake, it will start to use fat tissue, but it will also start to use muscle tissue as an energy source as well. Now, the problem with that is that also people's levels of muscle strength decrease, and it's that muscle pulling on the bones which is critical to maintain the strength of the bones. If that's not occurring, then the bone resorbs. It adapts as well to this low level of force that it's undergoing. People are less physically active, in part because they're dieting, they have less energy, their muscles are shrinking, their physical activity is reducing. So it's a downward spiral, which is also contributing, of course, to bone loss.
So on top of the great opportunity that we have with this GLP-1, GLP-2 drugs to reform healthcare, we're in this position where either pharma and we as a community healthcare community get the management of the use of these drugs with concurrent strength and conditioning referral and prescription, or it could almost make the situation worse long term.
Well, the evidence is, and there's several good papers, and we'll see some more, obviously, studies coming from this as the more of these studies are funded and there's more research done. But there's been a few key studies which have then looked at weight regain in these patients. Now, many of these patients can't stay on the drugs long term. Either the side effects accumulate and they go, I can't put up with this anymore. That, you know, I'm vomiting, I feel unwell, I just can't do it anymore. Also the financial issues as well. These drugs are quite expensive, and so people go, I just can't afford it any longer. When they go off the drug, the evidence is that they regain most of the weight back. And so over the subsequent 3, 6, 12 months, some of the studies show around 60% of the weight lost is regained. The problem with that is all of that weight regain will be fat. They don't regain it as muscle. The reason why is they're not performing any exercise, and in particular, they're not doing resistance exercise. So there's no driver for the body to actually lay down muscle. So as they put that weight back on, it's fat. Their muscle has been reduced during the during the use of the drug, that phase, during the weight regain, the fat has gone back up. So the actual ratio of muscle to fat is actually worse than it was before they went on the drug, which means that their risk of metabolic syndrome, cardiovascular disease, sarcopenia, osteoporosis, etc., is actually worse than
So
it
the
was
chronic
previously.
disease multi-morbidity ratios potentially could be
Yeah, it puts them in a
incremented
worse situation. Yeah,
if
absolutely.
there was no intervention at play in between.
Yes.
What
And that's the
are the key pieces of research that you've seen, Rob, around, you know, what have there been some good pieces to date around the impact of strength and conditioning in these cases with GLP-1, GLP-2 drug use?
no. Not to my knowledge. I've had a look at the clinicaltrials.gov, which is where most people would register these trials, and I haven't been able to see anything as yet. So no one's actually evaluating the impact of a targeted exercise program to overcome these quite problematic side effects of the drug. But we can draw inferences from other research. There's a wide range of research, particularly looking at the, say, bariatric surgery, where the same problem occurs. People receive surgical intervention and they lose weight, and the evidence is clear that if they are physically active, in particular if they do resistance training,
Yeah.
that they can maintain and prevent a lot of that side effect of muscle loss. So I think we can probably safely say I can't see that the GLP drugs would interfere with muscle growth in the right environment, but it has to have the stimulus. You have to do resistance training.
Yeah.
I think also, which is a problem, is that the recommendations which are placed around this by the clinicians who say, well, you're trying to lose weight, so you should do exercise. Everyone should do exercise, of course, it's important, but they're saying, look, if you do exercise, and they're recommending walking exercise to enhance the weight loss. My argument would be that actually that type of exercise is contraindicated. All that does is create a greater energy imbalance, so it's more rapid weight loss. With more rapid weight loss, the proportion of muscle loss is greater. If you're aiming to, and this has been established over decades now, if you create a relatively small energy deficit and you lose weight more gradually over a longer period of time, the proportion of weight loss from muscle is much less. And so that's the problem with these drugs. You have such, you have such a huge energy deficit because you just don't feel like eating. Also, you're being told by your clinician, and also if you read the recommendations around the drug use from the actual companies themselves, it does say, quite rightly, that you should exercise. And then it recommends walking exercise. In some cases, they say low impact exercise, walking. The problem with that is it does increase the energy deficit, which is not necessary. They're already not eating. They've already got a large energy deficit. There's no need to put anything additional on top.
Yeah.
But also, again, it's not addressing the muscle loss. There is no driver, physiological driver of walking or any aerobic exercise, which is going to counteract the problem of muscle loss. It has to be high intensity resistance training.
And I think, very similar circumstances, exercise medicine is coming into this space now, Rob, thanks to a lot of the research you've driven, a lot of research, great research globally. But another particularly impactful researcher in Belinda Beck, similar scenarios with she, like you, is very strong and knowledgeable in that strength space and has put together a protocol that shows efficacy for bone mineral density. And so really what you're saying is that there is we need to be working towards concurrent prescription and dosing of exercise medicine in the form of hypertrophy-based strength and conditioning work while on a GLP-1, GLP-2 drug, which I guess
Absolutely.
would also help impact the gut disturbance potential and those links that we know with regards to muscle mass's impact on the signaling around gut health and the interfaces there.
Certainly. I think that a key message here is that exercise is not a single medicine. I mean, Belinda's work is world leading. It's outstanding. And what she showed was that Exercise recommendations around swimming, for example, or walking have no benefit whatsoever for bone health. You're just not providing the right medicine. It requires resistance training, impact loading, so things like hopping, skipping, jumping, etc., to produce the physiological adaptations in the bone. It's the same thing with muscle mass. It doesn't respond to walking in terms of growth, in terms of hypertrophy. It needs resistance training and a certain type and targeted, very highly specific. And that's where we move to now in clinical exercise physiology, is very much tailoring the exercise prescription to produce the outcomes we want. Physical activity is great. It's good for everyone. We could do a lot better. We need to be more targeted. I think also associated with that is that if the people are not, they're obviously dropping their food intake because they're just not hungry anymore. We need to supplement them with protein as well to ensure they've got enough protein. And also, I think there's some very, very sophisticated ways in which we can drive muscle hypertrophy within patients. We know an enormous amount, an incredible amount of how to drive muscle hypertrophy because the research has been done in soldiers, warfighters, if you like, elite athletes, and also, of course, in the space programs, in how do you actually hold muscle on an astronaut? Because that's the major challenge to space travel. It's not how do you build a spaceship and get it to go to Mars. That's easy. That's the easy part. The hard part is how do you keep muscle and bone on the astronaut so that they don't disappear, waste away. That's the challenge of space travel, is maintaining muscle and bone. So enormous trillions of dollars have been invested in how do you actually induce muscle hypertrophy. Yeah. So we know that. We just need to apply that in the clinical setting with the patients on these drugs. I think also you are correct. It's a bit of an inference. We do need to do the trials, and that's probably a priority now, is to actually do trials using exercise medicine as an adjuvant to these weight loss drugs. We know that in patients who have nausea associated with chemotherapy, that exercise greatly suppresses the nausea, and there's clear mechanisms for that. It may be the case with these drugs. What I would propose is that the drugs could be used at a lower dosage. And now, obviously, they've been trialed and they've been approved for a certain level of dosage, and the medical practitioners have to stick with that because that's what's been shown. I think we need trials to show, hey, if you reduce the dosage, but you accompany that with targeted resistance training, you may get similar, or might be a little bit slower fat loss, okay, but you won't lose muscle, and you also might be able to stay on the drug for longer term, simply because you have less side effects, and also the cost will be lower per month as well.
So fascinating space, Rob, and I thank you so much for your time this morning. I always like to ask in closing, I think one of the things in healthcare and medicine is often, if it was your sister or brother or father or mother, what would your advice be to someone that was taking a GLP-1 or GLP-2 with regards to their exercise?
Oh, look, I've got to be honest with my patients, and you've seen many thousands of patients as well. I think that this is a game changer, these drugs. But I would say to my close relative, I'd say that, okay, well, the day you start the drug is the day you start the resistance training program that I'm prescribing for you. Yeah. And we're going to supplement you each day with protein at about 1.8 grams per kilogram body weight. That's a relatively high. Certainly if you've got kidney issues or anything like that, you wouldn't prescribe at that level. But for anyone else, that's fine. And that targeted resistance training and doing, I'd pull out all stops. I do some pretty sophisticated stuff around what we do with athletes to make them big and strong. And I'd get my sister or my auntie doing that as well. She'd
be the leanest power lifter by the time she was finished.
Absolutely. nothing like deadlift.
That's it. Well, thank you so much for your time today. It's been invaluable. And so much more to talk about. I look forward to catching up with you. I know that you have a few things in play, and I'll be looking forward to following closely.
That'd be great. Thanks, Katie. Thanks for your time. Bye.
Thank you.